And between the spinous process, there is the interspinatus ligament. Here we can see this one between the between two spinous processes, interspinatus ligament. And just behind the spinous processes, this is the supraspinatus ligament. Okay, let's repeat it. Why we are talking about the ligaments right now? Because once we start talking about the MRI spine, we have to comment on the ligaments, the integrity of the ligaments. So let's see, let's revise it. The anteriorly most ligament that attaches the anterior vertebral bodies. This is the anterior longitudinal ligament that is shown in the red color. Just behind the vertebral body, this is the posterior longitudinal ligament. And this is the canal in between. Just behind the canal is the uh, ligamentum flavum, usually yellow color in the when we see it macroscopically. And then between the spinous processes, this is the interspinatus ligament, and behind these spinous processes is the supraspinatus ligament. Now this is the MRI scan, and now again we can appreciate all those ligaments. Blue in color here, it is the anterior longitudinal ligament, just anterior to the vertebral bodies. Behind the vertebral bodies, this ligament here shown in the red color, these ligaments appear hypo-intense on the MRI scan. We'll see in the next picture where these colors will not be visible, so we can appreciate them. Just behind the canal is the ligamentum flavum, just here. Between the two spinatus processes, there is the interspinatus ligament. And behind all these, this ligament here, shown here, it is the supraspinatus ligament. Okay, when we start reading the MRIs, MRI of the spine, as we see in this picture, again, we have to first of all comment on which cut is this. So by looking at the CSF, as we can see here, the CSF here is hyper intense. So this is a T2 sagittal cut of MRI cervical spine. As we can see, most of it, the cervical spine here. So this is the MRI cervical spine T2 images, in which we are appreciating ligaments, different ligaments right now. This is the spinal cord in between, which is iso intense. Now moving on to the basic structures that we have to look for in the MRI. All right, so let's first start from looking at the major structures. So you can start identifying the MRI from the dense. When we are looking at the MRI of the cervical spine, so first of all, let's appreciate the dens. And just anterior to this dens or the vertebral body of C2 vertebrae, we can see the arch of C1. This is C1. This is the posterior arch of the C1. This is the brainstem, pons, medulla oblongata. Behind would be the cerebellum. This bone here, this is the clivus. Other structures that we can appreciate here in this picture, again looking at the ligaments, the anteriorly situated ligament shown here in the pink color, it is the anterior longitudinal ligament. Just behind the vertebral bodies, here it is the posterior longitudinal ligament. Posterior longitudinal ligament. This is the spinal cord in yellow color. Just behind it, there would be the ligamentum flavum. These are the spinous processes. Between the spinous processes, this is the interspinatus ligament. Just behind the vertebral body running ligament is the supraspinatus ligament. Now let's go to the MRI of the same sequence and let's see the structures. How do they look in the MRI? Okay, so again, this is the MRI cervical spine sagittal cut. Here we can see in this scout picture that from where this cut was taken. When we are commenting on the MRI spine, we always start from the central cut. As it is shown, this cut is taken from the very center. Other cuts which are given, usually these are paracentral images from right to left side. But how we can appreciate this is the central cut, because we can see the vertebral bodies here. These are very intact and solid. In the rest of the cuts, we'll see a bit of haziness that signifies these are taken either from the right side of the vertebral body or from the left side. Similarly, the spinal cord can be clearly seen here. In other pictures, it will start disappearing, means that would not be taken from the very center cut. Now, appreciating all those structures that we just saw in the diagrammatic picture, let's start it from drawing it from the C2. This is the dense process. Just anterior to it here, it is the anterior process. Anterior process of the C1. This is the posterior arch of C1. This is the dorsal process of C2. In between them, we can see a ligament here, that is the interspinatus ligament. Just anterior to it would be the ligamentum flavum, not very clearly seen here, but we'll see in the axial cut. This ligament here, which can clearly be seen, this is the posterior longitudinal ligament. Anterior to the vertebral bodies, this one here, it is the anterior longitudinal ligament. This is the oropharynx, nasopharynx, oropharynx, and here this is the laryngeal area, laryngopharynx. Behind this, these are the muscle interspinatus ligaments. Another thing that we have to comment on looking at the MRI cervical spine is the cervical lines that we'll look just in the next few slides. We'll see those slides and appreciate how we can. Okay, coming to the axial view, in the same way, we need to appreciate a few things. So this is a very complicated and busy slide, but usually in the radiology, we get the specific cuts of the spine just like this. Sorry, let me draw it again. Okay, so usually we get these kind of the cuts in the axial view, in which we can appreciate. Let's see, this is the C2 dense process. These are the arches of the C1. This is the transverse ligament. This is the tall. This is the actual canal. In between, we can see the spinal cord. These are the important structures. This is the foramen of transversum, through which the vertebral artery is going to cross at the lower ends. The rest of the muscles and the things we don't want to comment on right now. We just want to appreciate the important structures that we'll see in the next cut. Okay, so this is the axial cut. Again, first looking at the scout picture. This scout picture shows us shows us that these axial cut, transverse cuts were taken at this level, where we can see the C1 at the level of C1. Here again, these are the arches of the C1. In between them, this is the dens or the odontoid process. Just behind the odontoid process, keeping it in its position, is the tall transverse axial ligament. And just behind it, this is whole is the canal. In between, this is the spinal cord. Isointense, just behind it, there would be CSF. Here it is C2. These are the important structures that we need to see. Now, as we go down in the lumbosacral region, again, we can appreciate all these structures. These are the vertebral bodies. In between the vertebral body is the intervertebral disc. The vertebral disc itself can be divided into two parts: the central gelatinous material, that is the nucleus pulposus, and annulus fibrosus, that is covering the disc. Coming to the back, these are the dorsal processes. There is the lamina. This is the transverse process. Anterior to it would be the pedicles, which keeps it attached to the vertebral body. And these are the ligaments. Behind this is the just behind the canal is the ligamentum flavum. The canal is anterior to it. This is interspinatus ligament between the spinatus processes, and supraspinatus is going to cover them from outwards. Now let's come and see all these structures in the focused MRI lumbosacral region, in which we can see. Let's start it from anterior. This is the anterior longitudinal ligament here. These are the vertebral bodies. This is the intervertebral disc. Just behind it would be the posterior longitudinal ligament, blackish area that we can appreciate here. This is the spinal cord that ends up around L1, and then we see the continuation of the theca. Behind, we can appreciate the ligamentum flavum here, which is tightly related to the canal. Now these are the axial cuts. In the axial cuts, we can again see the same disc as it was apparent in the diagrammatic picture. This is the annulus fibrosus. This is the central portion, that is the nucleus pulposus. Going at the back, looking at the canal, this is the canal, in which we can see the theca, not the spinal cord, but the theca. And these are the small nerve roots that are going at the back. In the spinal canal, it is filled up with hyperintense. So these are T2 cuts. Behind, we can see this thick ligament. This is the ligamentum flavum. Again, looking at both the cuts together now, these are the MRI lumbosacral spine T1. As we can see, the CSF is brighter here. These are the T2, as CSF is dark here. We can appreciate the spinal cord, which is ending up here at around L1. And then there is the theca moving downwards. Similarly, on T1, the spinal cord has ended somewhere here, and below is the theca that is moving downwards. So looking at this is very important. Why? Because a very important condition which we see in the neurosurgery, that is the tethered cord syndrome. What is tethered cord syndrome? It is the low-lying spinal cord below the level of L1 in adults. As we can see in these pictures, here we can see the spinal cord is still moving downwards. This is the T1 cuts. We can see the spinal cord, this hypointense area which is ending up around L4 level. Similarly, T2 cuts, as Dr. Majabin told, these are very important to pick up any pathology. So similarly, here we can see this is spinal cord, which was supposed to end at the L1. It is still going downwards, and this is some kind of a tissue which is holding it downwards. This is thick phylum terminale actually. Okay, now the lines that I was talking about. So we'll not go into the detail of all these lines. This will become a bit complicated. So important lines are the Macrae's line, which extends from the clivus to the opistheon. This is Macrae's line. This basically is the opening of the foramen of magnum. The structures of the brain should not come down below it. The structures of the spine should not go beyond it. That's why this line is very important. This is an imaginary line. Similarly, this is the Chamberlain's line. Chamberlain's line extends from the hard palate to the opistheon. And one structure that we see that is going beyond it, it is the dense process of the C2 vertebra, which is usually just 3 mm above it. It should not go more than 3 mm above it. Now, identifying these lines is very important. Why? Because for the diagnosis of two important conditions. One is the Chiari malformation. Chiari malformation, it is the herniation of the part of the cerebellum below the foramen of magnum. As we can see in this picture, these are the tonsils of the cerebellum that are protruding downwards. This was the line, Macrae's line, that we drew in the last picture, and we can clearly see a portion of cerebellar tonsils that is going beyond. Chiari malformation is a condition which presents with the different signs and symptoms, of lower cranial nerve palsy, cerebellar symptoms, and spinal symptoms as well, because of the compression of the spinal cord. So to identify that or diagnose it, it's very important to identify these different lines, demarcation, below which the part of the cerebellum should not go. Similarly, there is another spinal condition in which the process of the dens goes beyond these lines into the crossing the foramen of magnum, going above beyond into the skull portion, that is basilar evagination. Disc herniation, it's a very common pathology. I'll be just after the anatomy of the spinal cord, I'll be discussing about a few very important conditions, the pathologies that we face in our field. That is the disc herniation. That is very important and very common condition that needs to be identified on the MRI. MRI spine is the best investigation to find out disc herniation. Coming to the disc herniation. Now let's see and understand how the disc herniates basically. We already discussed the disc has two parts, annulus and the nucleus pulposus. So this is the posterior longitudinal ligament. This disc portion is basically protruding out, that is compressing the ligament that is entering into the canal, and inside canal we have the spinal cord and the nerve roots that would be eventually compressed by this protruded part. Similarly, we can see in the next picture, the nucleus pulposus has now actually gone out of the annulus fibrosus, and that is spreading out. Now this is known as the extruded disc. We can see both on the axial cuts as well. Protrusion is the entire portion of the ligament or the disc that is coming out, whereas in the extruded part, this is the part that has leaked, or that has that is basically coming out of the annulus fibrosus or the outer layer of the disc. We'll see in the next portion how these will look on the actual MRI. Okay, so these are the four stages of the disc herniation, starting from the disc degeneration. The integrity of the disc is intact. In the prolapse or protrusion of the disc, still the integrity of the disc remains intact, but a part of it has protruded out, herniated out. In the extruded part, the internal nucleus pulposus of the soft portion that actually comes out. In the sequestered disc, which is actually the portion of the disc gets disconnected from its actual part and goes beyond the disk space. Okay, so this is the picture in which we can see here. Let's start identifying these structures. So if we identify this all as a sacrum, this is the L5 and this is the L4. So between L5 and S1, we can see here the disc that is protruding out, the disc herniation, which is causing the compression over the theca and the nerve roots. To comment on the disc, we always want to see the axial cuts. In the axial cuts, we can comment on how much the canal is being compromised. So in this picture, in the next picture, we can clearly see that this is the canal, this is the theca, these are the different nerve roots, and here we can see the protruded part of the disc that has compressed multiple nerve roots. If we compare more than the right side, it has compressed over the left side, but somehow it is central and paracentral disc. When we are defining about the disc herniation, we also want to comment on either the disc is central. This is the canal. In the central portion, if the disc protrudes out, that is known as the central disc. Then we have the paracentral disc. Usually, most of the discs are paracentral. The reason why, because the posterior longitudinal ligament is very thick in the center and it will not let the disc herniate out. But in the paracentral portions, this ligament is thin, and so the disc can protrude out into the paracentral region. If we go more lateral towards, that is the foraminal portion. If we go even beyond that, this is the extra foraminal portion. Most commonly, the disc that we see in our practice, the disc is usually in the paracentral portion or in the foraminal zone. Now, this is the arrangement of the nerve root inside the canal. Looking at the cuts, first let's see the upper one. In the upper cut, as we can see, this is the L5 vertebra, and so we are commenting on the L5 nerve root of L5, right? So in the first upper cut, we can see the nerve root is very closely related to the vertebral, to the theca. We cannot comment on it, we cannot easily appreciate it, but at the lower cut, we can clearly see when it has moved a bit far away from the nerve root, from the theca, we can clearly identify these nerve roots. Identifying these nerve roots is very important because as we discussed about the central disc at this level, Let's for example, let's comment on the L4 and L5. If the disc would be L4-5, the central disc is going to compress more the uh, nerve root of L5. This is the traversing root. Whereas if the disc is laterally placed, foraminal or extraforaminal, it is going to compress the L4 nerve root. Understanding this concept is very important because L4 and L5 disc can present with the symptoms of L4 or with the L5. Usually it will present with the symptoms of L4 because extraforaminal or the paracentral disc is going to compress it. This is again the same example of L5 and S1. Here we can see this is a more laterally placed disc, so it is going to compress the S1 nerve root that would be exiting from here. These are again other examples of the nerve root. As we can the disc compression of the nerve root. Again we can see this is the laterally placed disc that is going to compress the nerve root of the right side. Okay, so now in this picture, we are actually looking at two pathologies at the same time. So first, let's start it from reading the MRI. These are the MRI cervical spine sagittal cut, in which we can see the compression of the spinal cord. Now we'll call it as the nerve compression of the spinal cord, which is being compressed both anteriorly as well as posteriorly. What is compressing it anteriorly is the herniated disc, but at the back we can also see a depression here, which shows there is compression from the back as well, which is being caused by the thickening of the ligamentum flavum. The most posterior portion of the canal is occupied the ligamentum flavum, and thickening of ligamentum flavum can actually also compress the cord. These all disease are part of the spectrum of degenerative disease, which includes the disc degeneration, disc herniation, as well as the ligamentum flavum thickening or hypertrophy. Moving towards the spinal fractures. Yesterday we discussed about the spinal fractures. Dr. Mahjabin talked about it, different type of the spinal fractures. So one of the type of the spinal fracture was burst type of the fracture, in which we can see here the vertebral body has been disrupted, and the part of it is going into the canal. Here we can see in the axial cut, more than 50% of the canal has been compromised. So looking at those pictures, now in the MRI, interpreting it on the MRI, in the MRI we can see there has been disruption of the vertebral body. At the same time, a portion of it has gone into the canal. Here we can see it is compressing the cord here, and cord changes, color changes can clearly be seen. Similarly, in the cervical spine, we can see here there is a fracture of 2, 3, 4, 5, 6, 7, C7 vertebrae fracture. There has been subluxation of C6 over the C7. Interpreting same on the MRI, we can clearly see here there has been a subluxation, a part of disc, a part of vertebral body that is compressing on the spinal cord, and clearly we can see that it has indented the spinal cord. At the same time, we can see color changes, the cord contusion here. Now coming to another common pathology, that is TB spine. These are the important features or the things that we see in our practice in the TB spine, starting from the sagittal cuts. In the sagittal cut, we can clearly see the integrity of the vertebral body has been compromised. There is some part of it that is going into the canal. The disc has also disrupted, though it is involved late, but it can be compromised. Similarly, we can see all those changes in the T1. Commenting on the axial cuts, we can clearly see here a paraspinal mass. This is the TB abscess causing the paraspinal mass, that is causing here the compromise of the canal, that is causing the vertebral body damage here, and it is also going towards inside the canal, compressing over the cord of the theca. Important thing in degenerative changes are the modic changes, and in the modic changes, basically we see the end plates. The end plate disruption occurs, which can be picked on T1. Initially, it appears hypointense on T1, hyperintense on T2. Modic changes too, when it progresses, it appears hyperintense both on T1 and T2. Further on in the Modic 3, in the advanced disease, we can see there is disruption of the end plate, which is causing hypointense, which appears hypointense on T1 as well as on T2. These are the osteophytic changes around the vertebral body. Okay, another common pathology is the Syringomyelia. Here we can see within the spinal cord, this is the intact spinal cord. In between them, we can see a lesion which appears hyperintense on T1, which appears hypointense on T2, which is non-contrast enhancing. So this is Syringomyelia, as it is following the same signals as the CSF, both on T1, T2. It is contrast non-enhancing. So this is a condition known as Syringomyelia. Moving towards the spinal tumors. Now, the spinal tumors can be divided into three compartments: extradural compartment, intradural, but extramedullary, or the intramedullary tumors. One by one, we look at all three of them. So first of all, starting from the intramedullary tumors, which are usually ependymoma, astrocytoma, or the hemangioblastoma. We can see in this picture, starting from the sagittal cut, when we follow the normal spinal cord, here we can see some signal changes here. There has been a thickening of the spinal cord, and so we are suspecting there is some lesion. Similarly, on the T1, these are again the signal changes. When we look at the axial cuts are the actual cuts on which we can comment either the lesion is extramedullary or extradural. Here we can see what it has done. Actually, it has expanded the spinal cord. All these are the boundaries of spinal cord, and we can see within them there are the color changes. It appears hyperintense on T2 and hypointense on T1. This is the tumor which is lying inside the spinal cord. Instead of moving the spinal cord, as we'll see in the next pictures, compressing it from one side, it actually expands the spinal cord. Now coming to the intradural but extramedullary tumors. Here we can see this tumor, which is extradural as well. This is the intradural portion of the tumor. It has compressed the cord towards one side, but it is not arising intramedullary. Similarly, we can see here in this MRI, this is the tumor that has compressed the cord towards one side. This is MRI T1 contrast. So this isointense portion is the cord, and this is the tumor which has compressed it towards one side. This is extradural, intra plus extradural, but not intramedullary tumor. This is another example of a intradural tumor, which is compressing the cord towards one side. This tumor is present on the left side. We can see it on the MRI sagittal cut. This is the tumor. Here is the tumor on T2, which is appearing hyperintense. Here it has clearly compressed the cord towards the right side. Coming to the meningioma. These are the post-contrast images in which it is homogeneously enhancing. Meningioma also is an intra. It can also go extradurally as well, but it is extramedullary tumor. So here we can see this tumor has again compressed the cord towards one side. At the same time, it is homogeneously enhancing. So it is an intraspinal meningioma. When we talk about the intradural but extramedullary tumors, there are two common varieties. One is the schwannoma neurofibroma. Second one is the meningioma. Coming to the third compartment, that is the extradural compartment. Usually the mets or the tumors that are arising from the bone compress the cord coming extradurally. So here we can see this is a tumor that is basically arising from the C3 vertebrae. It is going extraspinal as well as it is going inside the canal as well. We can see clearly on the axial cuts, this is the tumor that is arising from the vertebral body. It's a chordoma that is going inside into the canal and also compressing the cord but not involving it, and it remains extradurally. Here we can see a clear demarcation between the tumor and the cord. Coming to a few congenital conditions, one of them is the myelomeningocele. The important things that we want to look in the myelomeningocele is, first of all, we have to see the CSF signals, follow the CSF signals. So this is the swelling is filled up with the CSF. At the same time, we have to see this is the spinal cord that is going downwards, and a part of it is also going inside. So that's why we are calling it as the myelomeningocele rather than the meningocele. So we want to look at the where does the cord lies, and is there teething associated with the teething as well, as in this case the cord is going downwards. So while repairing the MMC, we also want to do the untethering of the cord. These are the again pictures that is showing a part of the theca or the cord is also going inside into the nerve roots that are also going dysplastic tissue that is going inside the swelling that is present at the back. Okay, this is a example of lipoma that appears hyperintense both on T1 as well as on the T2. So this is an intradural lipoma that is surrounding the cord. And again, in this picture, we can see the cord is low lying. So that is one of the cause of tethering of tethered cord syndrome. That is the lipoma. This is the example of Diastometomyelia, in which we can see in the axial cuts clearly that these are the two cords. The cord is divided actually inside. These are the T2 cuts. CSF can be seen surrounding it, and the cord is divided into two. So it appears as the eyes. I think we have discussed a lot of conditions. So that would be it from my side. If there is any question, any query, you people can ask. Is there any question, any comment? Dr. Mazibin, are you here?
Yes, I'm here. So I think if there are no questions, then welcome, Dr. Sana. If there are no questions, then we can just call it a day. I hope this 2 days course was at least enough to familiarize the participants with the basics of CT and MRI. And we love to